Board of Directors. The first thing to do is, can you hear me okay, Ross?
Yes, hear you great.
Okay, thank you. Is the approval of the agenda.
I'll make a motion as such.
Thank you very much, gentlemen. And Fred, if you would lead us in the Black salute, please.
Y'all please stand. Fingers in the corner, right hand over your heart, and begin. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you.
For those that would like to remain standing, please, I'd like to do the invocation. Lord, it's with a heavy heart I just want to come before you, Lord, because I know that you can lighten the load. Lord, with all the weather and the flooding and the loss of life, Lord, and then all of the things going on in this world that just seems where there could be hatred and discord along the lines of many, many people, Lord. I know that if anybody can heal our hearts and heal our land, that would be you, Lord. And I also ask that you specifically be with everyone in this room and the board members as we discuss the business of the Kern Valley Healthcare District, Lord, because these things that we discussed, the old things from the past and the new things that we have to make decisions on today, I just ask that you be with each one of us, calm our hearts, Lord, and be with those that are in need of any unspoken prayer. I just come before you and ask you for all these things in your name. Amen.
Question. Do you have a motion to approve the agenda?
Yeah, first, second.
So the,
Do a roll call.
Oh, sorry. Like you better in the little box up there. Just kidding, that's not really true at all. Okay. And it's gonna be by roll call, not by all at one, because not everybody's in their room. So Fred?
yes.
Yes.
Jean? Yes. Ross, your vote?
Yes,
John, your vote?
Yes.
And I'm a yes. Thank you very much for that, Scott. I appreciate it. Really. That's okay. No, that you're doing your job. I will make sure you get paid this month.
Can I ask a question?
Not yet. What?
Do we have to pay you extra because you're
Yes.
running the meeting?
No, because I have this.
Okay, cool. Thank you.
Okay, just making that clear. Number 3, the approval along with the agenda and stuff in the call to order, is the mission statement. It says we will provide high quality, efficient patient care services that respond to the community and provider needs. This is one of those things. I'm just gonna make a quick statement real quick because I'm in a statement chair. Some of these things that in my prayer that I request prayer over is that our mission statement, that this board and that we are capable of fulfilling this need to not only those that are employees here, but to the community. We will provide high quality, efficient patient care services that respond to the community and provider needs. We will provide leadership and health promotion and education for our patients, residents, medical staff, employees, and community throughout the district. So at this time we're going to move on to public comment. If there's anybody here that would like to make any comments, if there is, you have 3 minutes to do so. No comments? We're going to move on to the consent agenda. Just as a reminder, the consent agenda are the following items that have already been considered routine and are non-controversial by the hospital staff. Consent items are listed as action items and may be approved by one motion if no member of the board member in the audience wishes to comment and ask questions. If comment or discussion is desired, the item will be removed from the consent agenda and be considered separately. So do I have a first and second?
I'll make.
Catherine,
Yes.
I'd like to remove item 8E, Dr. Chris Hall's contract. I'd like to discuss that.
I'm going to make a motion to accept it as revised.
Any other changes or the second motion, please?
Ross, do you want that moved to new business item 4 or old business?
Either way, old business is fine since we talked about it last time.
All right,
Okay, that'll be moved to old business F, as
F1.
number 1.
Thank you.
You're welcome. So we have a first with the changes. Do I have a second?
I'll second. Second with changes as noted.
All right, thank you. And Fred, your vote?
Yes,
Jean, your
Yes.
vote?
Yes.
Fred, your vote?
you already said Fred.
Oh, I did, sorry. I do that a lot. You guys are just the same
Just having
height.
fun picking on you.
It's okay. John, your vote?
Yes.
Thank you. And Ross, your vote?
Yes,
Thank you.
Right, your vote.
I'm a yes.
Okay, just check.
I had to think about it because
I gotta watch how you got the gavel.
I know, well, you see you moved it to the other side. So, we will let
It's $5.
$5. So with everything that is approved, then we will be going to, reports. And Tim McGlue,
Okay.
have I missed something? Just in case. They did think I had beer in my cup, but I didn't.
Just, a lot of things, happening. Exec team is, this last week, spent quite a bit of time looking at new wage ranges for staff. This is for the non-management level positions. Normally those get updated every year. Since Chet had left and we changed with CFOs, that kind of stopped. So we thought it was time to go back and we redid that. We engaged, actually acquired data from HASC, the Hospital Association of Southern California, that basically looked at, 109, more than that even. Hospitals. Yeah, hospitals that placed by position, placed what their ranges were, their high and low, medium point, so forth. And so we wanted to at least be able to create ranges that see where our staff fell within existing ranges for other facilities, and so forth. But for the most part, the vast majority of our staff fell within those ranges, which we were very happy to see. There was probably, how many? 24 that fell out. We went through those, decided some of those, we're going to have to raise up. Others we're going to basically freeze in place because they're above the top of those new wage rates that we set, and so forth. And so the exec team will be sitting down with each of our respective departments and going through any of the employees that were impacted by those. So that is in process. Then once we have that, then each year as we go through the adjustments to the pay scale, we'll just slide the whole thing up the range, the wall, and go up accordingly. So we just had a minimum wage adjustment July 1st that went into effect. And so we're making the modifications now to get those changes made for the employees that were below the $18, that were at 18 or above. Like the new range is 1863, 63 cents.
The stats you were using from the association,
Yeah.
were they updated to the minimum wage?
Most of them were higher. I mean, because they're
No,
filling.
no, was their figures, were they using as on the average, all of them, the minimum wage? The new one?
I don't know what the time is.
Yes.
Yeah, everybody.
Say yes.
It's 2020.
Did you check that? You know that? Okay,
Can I ask another question? Are you done?
yes.
Can I ask how many in that 24 were, below? Because you said there were several that.
More of them were below than above. So,
Okay,
again, we have a bunch of CNAs and so forth that felt that we are having to move up.
but with the total number of employees we have? I mean, that's pretty low considering the number we have, isn't
Well,
that?
give me a second. I'll give you some. I just sent all this out
Okay,
30 minutes ago. So there were, with the minimum wage adjustment that is now in place for this, there are approximately 44 individuals that are being affected by these changes. 44%. And roughly, just looking at this, I would say 2/3 of them were increases. The other 1/3 are wage freezing wages because they were above.
okay. Thank you. I think that's pretty good considering the number of employees we have.
Precisely.
So, okay, thank you. Sorry.
And I could add to that the majority of the increases were to fall in line with the new minimum wage
Right.
versus some other adjustment that was needed. There were very, very few that were somehow below what the standard was.
There were
That
like
were
two or three. that
Yeah,
were
I mean, just,
Okay.
very-
it's not like they were way below. It was pretty close.
Well, yeah.
Brought it up.
Well,
Some were like a penny below.
yeah, I mean, I didn't figure it as much. I just figured that because I know it's something that's been continuously being worked on for the last,
It's taken us forever to get our HRIS system to be able to, for a feature within it to work. It was really important to get that feature to work because it saves us the hassle of this in years to come. So it's like, spend a little bit more time to do it right this time, and then in years to come, the whole process is 10 times faster.
nice. All right. Thank you. That's good. Sorry, Tim. Go ahead.
No problem, we had a CHA meeting, yesterday morning. John and I attended on that one. It's really to go in and take a look at the impacts of the federal and the state budget changes that were coming down. There was a lot of discussion obviously going on with that, issues regarding the fraud and abuse cuts, the impacts on the MCO tax, which is managed care organization tax, in terms of whether that was going to survive or not. Issues with state directed payments. They were going to be capping that at a certain 100% of Medicare rates, and so forth. And so a lot of these changes that were put through are not even going to impact us until at least 2008. And even then they have a rollout period of several years beyond that.
Like this win,
2028.
2008.
Sorry.
We're going back in time. We're
Oh, I-
in trouble.
I'm glad you're listening, everybody.
I think you're right.
So anyway, back to the future. So again, we took, John and I really spent a lot of time just taking a look at, the impacts on us in terms of where certain cuts were being made and how that might impact us. John had a conversation with Ryan Witz from the District Hospital Leadership Forum. They're anticipating that the impact for us might be around 30% of our supplemental payments that we're looking at. We get anywhere from about $10 to $12 million of supplemental payments. So that would be about $3 million cut that we would incur. This doesn't impact what we get paid for the services we provide in terms of a day rate, being in the hospital, those kinds of things. This is all on an additional cost and things like that. So
Hey, Tim.
yeah,
Hey, Tim, this is Ross. Is there any way you can get a little closer to the phone or speak louder? I'm having a really hard time hearing you.
We said that way.
is that better? It's a voice that's just going on too.
It's down on this side.
It still said that. Oh, there we go.
There we go. Are you there, Ross?
No,
We'll have to call.
Oh, you did.
Sorry.
I didn't see him up there, so.
I'm done with this. God gave him the go ahead. It was like, he did that. quick. I don't know if anybody else saw it.
One started ringing and it went away.
John, you there?
Yeah, I'm here.
Okay, we're trying to get Ross back on.
Did you take? Yeah, we could just get the number.
Oh, was he just on the phone or?
Yes.
Oh, okay, I was looking for him up before.
Think they'll answer.
Hi there.
We were trying to get rid of it.
again.
Yeah, Fred did it. So we moved the phone and it disconnected.
Thank you. Sorry about that.
No problem. You're good. Likewise. You had a question.
Okay, did you have a question?
Yeah. Ross,
Can you hear me?
I didn't have a question. I just couldn't hear what Tim was saying. So
Okay.
the report was kind of getting on.
Yeah, so
He was just stating that the IGT is gonna be 3 million less than it has been. We're only ahead about 1 million per year right now as projected. We're gonna be behind 2 million a year.
no, that's not true.
Okay,
It's what we posted in the books. The other estimate goes to reserves. So, because we've moved a lot of that money to cover for the building project and those kinds of things. So it's not,
so it just says that we're only making.
like I said, we get about 10 or 11 million dollars a year in supplemental payments. So a drop of 3 million or 30% would cut that.
I was just looking at the bottom line, Tim.
Yeah,
Okay.
yeah, that doesn't tie to the bottom line. So, John, I don't know if you want to.
That's true, yeah. We put some. Also, there are other ways we can probably make up for it too.
Talk louder.
Probably we can.
We can't make
Okay.
up for $3 million, but that's a worst case scenario too. It
Okay.
makes sense
okay.
anywhere from 15 to
It is a
30%.
possibility we're looking.
Yes.
Yes, yes.
Our thoughts at this point in time, if that's what it is, should be able to weather that. You know, obviously with some belt tightening, obviously some revenue generation, those kinds of things. So, you know, I don't think it's a death knell by any.
Oh, no, but
Yeah,
we need to address.
absolutely.
Yes,
Absolutely.
yes.
So, but, and I think that's really what we were trying to get out, and stuff like that. You know, their point is obviously there's some hospitals. We're very well situated financially, compared to most of the other rural hospitals in the state, in terms of the monies that we've set aside. And so, you know, there was some discussions on the call, even with regards to, you know, things they want to do. And, you know, it wasn't all the federal budget, it was the state budget as well, because the state's kind of held back, wait and see what the cuts the feds were going to put in play, before they decided what they were going to do. And so, you know, there was issues with the MCO tax where the state took money out of that for the general fund that was supposed to be earmarked for the providers as like 1.8 million and so forth. And so there's some questions now, like whether the MCO tax is going to survive or whether or not it'll be reduced with some changes they put in for how that money gets taxed. In other words, cannot tax Medi-Cal patients' revenue any differently than you do any other health plan, and so forth. And I think California had been increasing the amount that they taxed those Medi-Cal providers, and in order to get a larger federal match again, and gave it back to the hospitals and so forth. So those things are changing as well, coming down. But when it will happen and when it will be implemented, we don't know yet. I think that was a big issue. I think with the CHA people and their experts, DHM, nobody seems to have a real clear answer on how this is going to roll out. They're still in negotiations right now on various aspects of the bill and how that might be rolled out, whether they're going to do it or not, or to what extent they're going to do it. So everybody is still kind of just saying, we better wait and see what finally comes out of this and stuff like that. So it's just, you know, we look at the overall situation.
There was a rumor that Vince Vaughn got $500 billion for rural hospitals.
He didn't get it, no.
He did.
It was 50 billion.
50 billion for.
Oh, I thought-
10 billion each year for 5 years.
Is that just California?
No. that's nationally.
So that's not very much money.
Well, you're right, it's not. And so, as we learned, that $50 billion or $10 billion a year is going to be split evenly among the states. So states
1
with
billion
2 million people are going to get the same amount as California is going to get.
They should go by the size of the state,
They should.
population size.
Yeah, that's not the way it was written. So
Thank you.
anyway, so there's a lot of changes I think they're still working on right now. So we'll wait and see how that goes.
Ken,
Yes.
so the $50 billion that they're putting back in
Yeah.
is 5% of the billion that they're cutting. So we're not going to get any benefit from that.
There's really not going to be, from my perspective, like I said, that 10 billion is going to be split 50 ways at each state. So, I mean, there will be some that will come back to it's being, again, it's just for the rurals and so forth. So again, there will be some money that comes back to offset against us. But we'll just have to wait and see how that plays out.
It's not going to be much.
No.
Not like we're used to getting.
Well, no, a lot of those funds will still continue to come through. As a matter of fact, there are some of the funds that are anticipated to increase over the next 2 years, which would, what we were hearing was would have doubled what we got paid back.
And they're actually rushing through the next year. They were supposed to wait till next year. They're rushing the fiscal year 24, which is supposed to be later. They're rushing it through now, so it's fully absorbed by us. Which would be a good thing for us.
Right.
And it, like
For this year.
yeah, like Tim said, fiscal year 26 was supposed to be doubling our IGT. So that even if they take a cut of that, we could end up not as bad off as we think. There's still a lot of negotiations they're going to. There's a lot, even California Hospital Association still says there's a lot of uncertainties.
So like I said, we're just kind of waiting to see how that's going to come down. There's lots of meetings that are being planned with each of us as they learn more and more details about that. Like I said, so right now they're still negotiating on a lot of pieces to this. So that could change dramatically based upon how those go. Power shutoffs are continuing. They started up again. We were out yesterday for a while, not very long, luckily.
15 minutes.
Yeah, I was surprised that they took the trouble to do that. I just got notifications they're believing that there's going to be shutting it down later today. So we'll have to wait and see. Our generators have been working great for the retail pharmacy, for the clinic. We are having little problems with the transfer switch in the clinic.
Already fixed.
Oh, is it? Okay, good.
What I did today.
New switch?
All the new
Got it. Yeah. Got the first one that was broken. The second one
failed.
was defective. Was working for a while, and then all of a sudden.
Do those come with the rental?
Yes.
Yeah. So we now lost the third one.
The cost doesn't change. They just
Right,
they brought us a brand new one.
You can't hardly do it without it.
Yeah. So that clinic has told me that, or the retail pharmacies, that they don't even notice it. They just, it's that fast and stuff like that. So they're very, very happy about that. But anyway, so like I said, we're continuing to monitor all that stuff. Bob's working on getting bids right now for some permanent generators. Because obviously we're going to have to get some of those, as we talked about, building and planning.
Yes, I got tentative numbers from Quincat. I'm getting expected numbers from Cummins, but obviously when we go to purchase, it'll have to go out to public bid.
Right.
And right now I'm waiting on a cost to draw the plans for the county from them.
Okay. Because those are not buildings associated with the hospital, those aren't going to have to go through Oshkosh.
No, Kern County.
Good. So I had a call with Adam Schiff's office yesterday. They are still wanting to help us out on the FEMA money. They were, we had a heart to heart and just kind of said, listen, I don't think that there's much effort worth going after the BRIC money. That's pretty much gone as far as everything's. Well, I said what I could use their help on right now is support for the Cal OES grant. Christina Barros, who I spoke with, basically got a hold of two of her people out here in California that have worked extensively with Cal OES. They've already reached out to me today We're gonna try and have a call tomorrow or Monday to figure out how they can help us out. Either a letter that the senator will write to Cal OES to put their support behind approval of our grant request. So we'll see what that does. Every little bit helps.
I forwarded all the county forms to them for their review. And if they want to make any adjustments from the last go around, they'll be sending those to us for signature. We are probably on front of the board of supervisors, so I think it's August 5th.
Okay. Still leaves plenty of time to get the rest of it completed.
What's that?
That still leaves plenty of time to get the rest of it completed.
Oh, yeah. Yeah, we're doing okay.
Very good. Juan Talapas has joined us as our new lab manager. He is going through orientation right now and anxious to start. He comes to us from Las Vegas area near Mesquite. He's up there running their lab at the hospital up there. And so glad to have him on board. It's the whole department interviewed him along with a bunch of other candidates. He was the one that they all liked the most. And so forth. I've gone through his resume, met with him twice. I think he's a good fit and anxious to get him going back there. So met with our managers team yesterday. The plans of corrections that we had for the SNP survey and for the life safety survey have been submitted back to CDPH. So we're waiting now for them to go through those, and then we'll see whether or not there's any changes we might have to make to those when they come back. So done that. Retail pharmacy obviously has been evolving. Obviously those volumes have continued to rise. I think this last month we saw 6,657 scripts down there, which is by far the largest we've seen in a long time.
Probably gonna be more this month.
Yeah, it looks like it's going to be more. Well, the nice part is like I said, now that the Rite Aid is closed, I mean, that's kind of capped now. So we've kind of peaked on that. We're getting some of their staff are now coming over. We had 3 clerks that are joining us from over there that have been working there for 20 years. So they're anxious to come work over here. So we're trying to get into orientation so we can get them onboarded. She interviewed a pharmacist yesterday morning and with her other pharmacists down there. He is willing to work weekends. So he'll work like a Friday, Saturday, Sunday, Monday shift so that we can be open 7 days a week. So
He'll be there, pre-employment on Tuesday, starting on the 20th.
okay, so he's accepted. Great.
So I took to see the 3 new techs will allow us to be open during lunchtime too. We'll never close.
Perfect.
We'll close at night.
That's a big thing.
Yeah.
We, again, the lines out there have been long. We may have driven by, Bob put up easy ups down there, 2 big easy ups that he bolted to the ground so the winds wouldn't take them. We put tubs of ice water out there with bottled water in there and so forth for people just to kind of keep them cool. I think you also picked up some coolers.
Coors, like in Coors beer?
Yeah.
Oh, I'm sorry.
Large.
I don't want to make the line any longer than it is.
Large evaporated coolers. And picked them up yesterday. We're running electrical for them today. And in the morning we'll install them so that if you're outside in line, you have electrical.
Nice, because those lines have been long.
You get dual packs so that if this thing carries on till
We can have,
time of the year, that
well, they'll be moved by then.
Yes.
We'll be able to.
We just wrap them around the building.
Knock on wood.
Yeah, I mean, the feedback we've gotten is they're very appreciative of the efforts we're making, trying to accommodate them.
Yeah, what I'm saying, one of my staff members is going down multiple times a day and restocking the IC more.
Right.
Should we be trying to sell that before they get cooled off tomorrow?
Get you water for a buck.
Free to everybody else.
Hey, Ken,
Yes,
this is Ross. I had a question on the pharmacy.
sure.
I didn't hear, is there any accommodation for the lunch hour to keep that open during the lunch hour?
Yeah, that's what John was just talking about. You might not have heard of we've hired 3 more techs that are coming on. And so we won't be closing down for lunch anymore. So once they're on board, so yeah, we've got that covered, and we've got the weekends covered now too. So with the
That's
pharmacy.
terrific. Good job.
So it's just, it's been a scramble. We even put a security guard down there. They requested that because we had a couple of instances that came up with some people that just got a little testy and so forth. And that helped. They actually were letting them in instead of having everybody just pile in the door. They would let 4 people in at a time. And when those were done, they let 4 more in. And I know there was a Facebook post the other day, someone standing at the back of the line who basically said, listen, the good news is the line is moving quickly. Because they can hear it's not so chaotic in there. They can focus on what they're doing. And so, and they said the staff have been wonderful. And so, very, very happy.
Today we took cones down there because we're setting up 2 lines. Those that are just there to pick up subscriptions that they know are ready versus those that need
Drop them off.
place. So
Good. So every day we're adding new things to it to kind of help, the traffic control and those kinds of things. So,
That's great. I was one of those people at the end of the line, and I was so impressed with our staff of how efficient they're operating. It was, you're standing in the parking lot and you're wondering, oh my gosh, how long am I going to stand here? It was only 15 minutes, which given the number of people and the amount of demand, that wasn't bad at all.
Yeah.
So they're doing a bang up job, but I'm glad we're able to accommodate the lunch hour thing because that was a bummer. I was in line at 11:45 and got turned away. So
Yeah.
and so did everybody else in line. So I'm glad we're able to fix that.
Yeah, we had some comment from somebody else in the community that's well known, and he was waiting for 2 hours in the line, got up to the door, and then all of a sudden they came out and said, "We're closing for lunch." It wasn't well received, needless to say. So we fixed that literally the next day. We had a solution for that and so forth. So these other changes, like I said, while we were waiting for these other people, they were contractually obligated through their union agreements to stay until the pharmacy closed at Rite Aid. So we could not get them in any faster than that. So, yeah, it sounds like we're getting it worked through, and that's great. It'll be a huge help for us. And they know a lot of the people in the community because they've been here for so long. So that's pretty much my report.
Thank you, Tim.
One more thing on the pharmacy. We had a meeting with the US Postal Service in Santa Clarita, and we're just waiting for them to respond to us. But they say it's not a problem to do it. Problem right now is we don't have space to do it. We're trying to reconfigure Suda's office so that we have someplace we can put these all together.
I met with her on that this morning and she's going to try and get it cleared out this weekend.
Good.
So we get that set up.
Good.
So thank you. So now we're going to go to item F, which is old business. And Ross, that is to discuss what you had for the contracts, number 8E.
Yes, thank you. On Chris Hall's contract, Tim, the question I had was, is this the same contract amendment that you brought to the board last month?
No, it's not.
Is it identical? Because we don't have any documentation on what we're approving.
This is the existing medical directorship, because again, when they go out, they're 3-year contracts. It's a 1-year contract renewable for 2 extra terms. So this is just rolling 1 more term. I'm probably going to ask us to just hold back on that for 1 more month. With other things that we need to talk about. It's not a militia. Nothing's changed on it or whatever. Same terms and conditions that were originally negotiated and approved by the board. So, like I said,
Bring it back next month.
we'll bring it back next month, right?
Okay, great. It'd be really helpful, to actually have the document that we're approving, so I understand what it is we're approving.
Yeah,
Without seeing the contract, I'm kind of in the dark.
yeah, like I said, it's one you've already approved. It was just the renewal of, the second year of that contract, so. Usually the new ones come in because it's new terms and we need to get those approved by the board.
So this is for the contract for him being an ER doctor. This is the contract for him being the medical director of the ER.
That is correct.
Okay.
Just an annual review for it.
Yeah, this is the annual review, and he was just saying that we'll bring it back in August.
Okay, super. Thank you.
You're welcome.
Please include the actual contract in the packet so we can take a look at it.
We'll do.
So this is gonna come back next month then?
Yes.
Thank you. Okay, on to G, new business.
Just so
Go ahead.
everybody knows, the notice just came through. Sees it's the second level that expects they're gonna shut off the conference center.
That'll be about 15 minutes.
Yeah.
John, you're up. You lose your place?
I did. That's like a good budget. We discussed the budget in finance committee last week. And I don't know if you want me to go over it again, Catherine, or how you want me to do it. Happy to go over the high points.
Yeah, if you could just go over the high points. I rewatched the so page 52,
Okay.
57.
Some of our assumptions that we had, we're going to increase the average daily census in the SNF from 48 to 52.8, which is a 10% increase. That'll increase our revenues by about 830,000, our net revenues. Clinic visits remain flat. Greg's getting close to finding a physician. And if that is the case, we find somebody, I'm sure that is an underestimate for sure, because we will have more business in the clinic if we have another doctor there. ER visits, we're going to have them going up 5%. We think with some of the changes that Mark has made in the ER, that is going to help the flow and it's going to increase the quality of care in there. And that should increase our business by 5%. Retail pharmacy, I've got going up about 26%. And right now that might be a low estimate too, the way it's going. But sooner or later, the other new pharmacy is going to open. We are probably going to lose some of this new business, most likely. I don't know how much. Nobody can really say that for sure, but we are still going to have an increase over what we had this year for sure. We started at 32, I think, at the end of fiscal year 2024. And as Tim just said, we're about 66 or 67, double. And I think July is probably going to be closer to 7,000 or so. So that is and we are also.
What do you know about, you mentioned other pharmacy. What do you know about? I haven't heard anything about it.
All we know is that they came into our pharmacy and told Sue that they're going to steal our business.
Oh,
They will run about 20 pharmacies somewhere around this area. It's a Indian, I don't know if they're doctors or probably pharmacists, and they run other pharmacies. I don't know if they have any connections in this area or not, but they seem to be pretty confident that they can take it.
They might have a problem
I think a lot
they
of,
might have trouble running over us.
Yeah, I agree. We'll do what we have to keep our
They're
business.
running TV commercials as well, Kern.
Yeah, I think the community is seeing what a good job we're doing under really tough circumstances, very tough. We won't see this again, hopefully, but we are doing a good job. And I think the community appreciates that. And I think they're going to continue to come to us. We just have to make sure we make them happy. And so far we are making them happy, I think. That's all the assumptions. I did not raise the prices this year in our charge master because after the Coral Health Charge Master review, a lot of our prices, we've been raised from 7% for the last, I don't know how many years. They're just too high and doesn't increase what we're getting paid because we're paid mostly on fee schedules, which Tim and I are working with Andy, working to increase those fee schedules, but it's not a percentage. These companies, payers do not want to negotiate percentage charges anymore because they're losing. That was good for the hospitals, bad for them. So we are trying to get that, but I'm not too optimistic that they're going to come with that. So we will just try to increase the fee schedule that they're paying us I have a expense inflation of about 3%. Average wage per hour increase RNs went up 12%. Average raise per other employees went up about 4%. That's about a almost 6% increase in payroll. And we have a capital spending of about 0.7 million. And there's a page there with capital spending. We'll go over that. IGTs, I made them flat, 10 million. I don't think anything is going to happen this year. That's probably an underestimate. We probably need to get closer to 12 or 13 million this year. But that's what I have. That's what I have in the budget right now. FTEs are going to go up about 0.03%. We increased. We had one increase in what I remember what department it was now. Debbie, do you remember what department that was?
You had an increase in water.
Oh, you are, yes. And retail pharmacy, that's the other one. Retail pharmacy was 1.2 and UR was a little bit less. So they're up by 0.5%. And paid FTEs are up a little bit, 1.2%. And our cash, I'd say it's going to remain pretty constant. Statistics show what I just mentioned on all of the assumptions. The acute going up 3%. We are working with Dr. Gross to try to make sure that we can have more inpatient services. We're having trouble right now getting some of them authorized, especially the swing bed situation. They are putting them mostly in observation because it's easier for them, but it's hard to get them out. That's the problem with observation. That we're having a little issue with that, but we are working with them to try to see if we can't get that going a little bit better. Observation pays us about 1,700 with certain, and swing pays us about 23 to 24, which is a big difference.
We got less work for observation than swing, though. It's done the way it's supposed to be.
No.
A lot of times there's more work, Gene, because it's the observation day is the initial day that they're trying to figure out what's going on. So there's even more testing, so.
And we're not getting paid for the testing because it's a per diem rate. That's the problem. So all the tests we do are pretty much included in that per diem rate.
And the observation, my understanding was when they went in, and they really didn't see that much wrong with them. When they spend a night, they wouldn't let them spend a night as a patient, but just lay in a bed.
Well,
Basic
insurance
fellow
companies are finding out that they don't have to do so much for the work still has to be done.
Yeah, and we're getting paid for it.
Not getting paid for the inpatient stay. That's the problem.
So we're putting out the same amount of work. Yeah, well, they don't think we are. So
Sure.
that's okay, true. Thank you.
We have outpatient visits going up 3%. And that's it on that page. There's our income statement is on page 55. We have overall revenues going up about 5%, 5.8%. And we have, like I said, salaries going up about 5.6%. Still have a little bit of a net loss in operations, but we make up for it with the non-operating revenue, which is contributions, interest revenue on our bond, our investments. We come out about $1 million and some change at the bottom line, which is pretty consistent with that this year.
Then again, continue. It looks like it from our investment.
We are looking for additional sources of revenue, which aren't been reflected in the budget. We're also looking at our AR a little more closely. I have a company looking at some of our denials right now, and I think we have going to change our process on that, try to get some more money in that respect too. I think we're leaving some money on the table right now, but I think that's going to change.
Cool.
Any other questions for John?
Mr. Rouse,
Go ahead, Ross.
John, I know this next year will probably be fine in terms of what's happening at the federal level with Medicaid. But our SNF patients are, largely dependent upon Medicaid money, although it comes as Medi-Cal money. So what happens in 1 or 2 years out with our SNP? What's your crystal ball look like? How are we going to continue to get Medi-Cal money for these patients, or is it going to just dry up?
I don't believe it will, Ross. I think we're going to continue to get paid these per diems. Even if they cut the per diems a little bit, we're still higher than cost. And if our census goes up, our costs go down. So that's leaving it better. I mean, I can't tell you what's going to really happen as far as some of these Medi-Cal and managed Medi-Cal. Depending on, there's going to be probably a shakeout of some of these managed Medi-Cal companies, I'd imagine. But we will we'll deal with it. We'll have to cut some of our expenses. We don't really know that maybe they get rid of some of the ratios, and that would help us on some of our costs. But there's still a lot to be said in negotiations, Ross, and I don't think we can really project what really is going to happen in 2 or 3 years right now.
Yeah, but Ross, just to continue on.
I've heard, the stuff I've heard, and it's just grapevine stuff. I don't know how factual it is, but what I'm hearing is that they're cutting basically housing for the elderly, for the ill. And isn't that directly impact our SNP revenue?
It depends where they're cutting. I don't understand cutting the housing. This isn't really housing. This is long-term care. If you're talking about like assisted living and things like that, maybe that doesn't affect us. So.
And Medi-Cal doesn't pay for assisted living.
No.
No,
Other times.
You-
In between.
you need to get out of Facebook, Russ. There's sort of a problem there.
Yeah, it's not Facebook. It's the traditional newspapers where I'm getting my sources. But
You're spending your money
it just
unwisely.
I don't know what's in the bill. I certainly haven't read it, and if I read it, I probably wouldn't understand it. So I haven't ventured into it. But when they talk about care for elderly and
Right.
the infirmed elderly, and they're not paying for their housing anymore, it sure has me concerned about what happens to our SNP.
I agree, because the elderly is going to get a bigger percentage of the population as they age, and they need to do something about it. I can't tell you what they're going to do, but we will.
The vast majority of the patients are covered under managed care plans, like Kern Health. And so those are all negotiated contract rates and so forth that they're obligated to pay for. Again, there's been no discussion with regards to cutting pay rates for any of the care that's provided. This has all been supplemental payment issues.
Or straight Medicare
Yeah,
in other states
correct.
where they don't have Medicare.
Some of the issues may be impacted by, again, whether or not there are certain people that are cut off those coverage files or whatever. But what we get paid for the service we provide is not being challenged.
Right. They may make it more difficult to qualify for some of these, but they may do. But as far as that goes, we don't know that yet, Ross.
All right. Well, please keep your ear to the rails and let me know what's going on, because I'm losing sleep over it.
Well, we all are, but we are listening to CHA. We're listening to what else did we talk to? Tim, we talked to somebody else too.
District Hospital Leadership.
Oh, yep, District Hospital Leadership. So they are all on top of it. They are advocating for us in Washington and Sacramento. And I don't think this is over yet. I think there's still a lot of negotiation to do. I think there's a lot of there's going to be some compromise too, I think.
Okay. Thank you.
Okay.
Let us know.
Okay. You want to go over anything else, Captain? Capital equipment or anything like that?
Does anybody else have any questions on it?
No.
No, I think we're fine.
All right.
Thank you, John.
You're welcome.
John, do you have any questions?
I don't, Catherine. I read through it before I came out to Kentucky. But this is an action item, so if everybody's okay, I'll make a motion to approve the 25-26 fiscal year budget.
And actually, let me say, we'll bring this back next month. It's an action item.
We'll bring this back next month as an action item, but thank you for
Oh.
being willing to make a motion.
Oh,
So
okay.
we'll roll it in with budget approval, the annual investment policy review, and the appropriations.
So just for clarification, I mean, it's listed as an action item. Is it just additional modifications being made, why it needs to be approved next month, or?
Yeah, we're just gonna table it so we can roll all of those into one.
Okay, gotcha.
If
Okay.
if you want to vote to approve it, you can vote to approve it, but next month we're gonna come back with a resolution.
They're gonna want to make changes to this or no, okay.
I don't.
Does it require a resolution?
So annually, the board adopts a resolution approving the budget, reaffirming the investment policy, and setting the appropriations limit.
Then we normally do them all three at the same time.
Yes.
You okay with John?
Yeah, okay.
Okay.
Doing a motion to table it or?
No.
No, okay.
We're going to move on to G2, which is the resolution 2505.
We have three pieces of equipment that have reached end of life. Beyond that, one is our BiPAP vision ventilator. It is beyond life. It's not working. Cannot repair that. So it has no useful value. That was purchased back in 2001, so it's 24 years old. So we're taking that off the books. The other two are old microscopes. These are so old, they have no property tags. They are not on the capital register. So we're just going through the motion to clear those off. One can't use it or whatever, the other is so far gone. And so they've already requested to receive new microscopes and so forth. So we're just going ahead and taking this off. Like I said, these have been here forever. So,
Can I ask you a question, Tim?
sure.
As a rule, we put stuff on here. That generator sitting out here that's probably 20 years old, it's only been run twice or three times in its lifetime.
This one right here.
Yeah. When will that go up for auction? Oh, are they gonna actually want it back?
No, it is part of the emergency supplies supplied to each
Oh,
hospital.
so we're just gonna keep it.
Yes,
just in-
we're actually gonna relocate it. And we're gonna put it on the HRS.
Oh, cool.
I have to run a study, I have to plug up a digital recorder and run a study on what the electrical problem is. If it meets the criteria for it, we're gonna move it up there.
Is that about an 18? What is that?
It's a 27.
27?
Oh, yeah, it's a big one.
Cool, cool.
So it shouldn't have any problem.
It is very probably going to work. I just haven't had time to look up the digital report.
That's
It's
awesome.
close enough to run off your propane.
I can run on that.
We can run it over to your propane line. We can give you an extension.
But man, that's so expensive.
Did you think about it when you parked by it? Is that when it just popped into your mind to ask that?
I've been watching it for 5 years.
No, it's still great,
Cool. Thank
but
you.
it is owned by Kern EMS.
But we might as well own it. They're letting us use it.
Yes.
I'll make a motion to accept as presented.
Can I have a second?
Second.
And,
Can
I'll
you
second, but
that?
I have discussion.
okay,
Just questions on the microscopes. Is there something, are those microscopes something that the high school could benefit from?
I don't believe so. How do you know more about that?
One needs repair and they don't think they're gonna be able to repair it. The other one may still have some life, but we need to surplus it. And Christina will research options as far as if we can sell it, if
Yeah.
it's worth anything. But the lab isn't using it any longer.
Did you hear any of that, Ross?
I couldn't hear Heidi, but I kind of got the gist that they're just junk.
No, she said
One
one
might be
Like,
useful.
one might be useful.
one might be usable, one is terminated.
Okay. Anyway, just a thought, and before we just dump them in the scratch, maybe we
Yeah.
could contact the high school and see if they could benefit from it.
We'll look into that.
It's very resourceful about trying to make use of it.
Absolutely.
okay, so I have a first and a second. Ross, your vote? John, your vote?
Yes.
Jean?
Yes.
Craig? And I'm a yes. Thank you. And then number 3 is the physician services agreement for Michael Green. Kim?
Yeah, this is one of the ones that was here last month. You know, again, Dr. Green is new to us. You know, he is wanting to come on board, work with us. This was at a rate of $300 per hour. We tabled all of them last month. And so for 3 of the 4 of those were contracts that had been recently negotiated that they wanted changed. This one was not in that category. We have since reached out. We've got a local tenants position that we're considering right now. That's actually going to cost us $350 an hour if we choose him. You know, again, because of holes in the schedule, we need to have this coverage. So, you know, really requesting the board to go back and reconsider on this one and give us approval to go ahead and.
Can I make a motion and we approve it as presented?
We need to retro it to May 1st, or is it?
No, I
You
don't.
can change the effective date. He hasn't been scheduled yet. He's gone through the credentialing process, but he's not on the schedule. We could even make it effective today if you guys. approve it. That's fine.
Yeah, that's good.
It's just the existing agreement that we had last month, but.
Yes.
Want to change the date to today's date?
Please.
We have a first. Does anybody have any discussion? Any questions?
I have questions about it.
Go ahead, Ross.
So the last time that the board talked about this, you know, we wouldn't accept, it was tabled. There wasn't an actual vote, but there was general agreement that the $300 an hour rate was not acceptable. And so how did that discussion go, Tim? Did we offer him 275, saying the board would only go to 275? Has there been that discussion?
There was.
That's my first question. The second is, this is retroactive to May,
No, we're.
and it's almost August. Did we hire him? Is he working in our ER?
No, that's the conversation we were just having with Heidi. He has not taken any shifts yet. We are still processing his privileges and those things. So again, he will come for 300. That's it. You know, he's not going to negotiate on that. He's a very good physician, I understand. And so his records indicate that. And so, like I said, it's just like I said, this got caught up with some of the others because they had been approved in 3 or 4 months before. And like I said, we just said, no, we're not doing that. Wait till the next anniversary date if we want to make a change to those things. So, but his was a clean contract as it was. Like I said, you know, we have compared that. We're like looking at a contract that right now for locums for another position that's $350 an hour. That's just what we're getting. I mean, and
350 plus travel.
A locums contract is always a short-term contract. That's just
Sure.
filling in for somebody because we don't have a contracted position.
Correct.
And you know what I'm concerned about is that the board has not been supplied any information to justify a $300 an hour rate. And that is going to affect every other position in the ER because they're all going to want that. As soon as we give it to one. And so by approving this at 300, we're approving everybody else's for 300 because they're going to come back and want that. And we still haven't done an RFP to see what a fair market rate is for our position. So all we have is anecdotal information. We have one guy saying, I'm not going to work for less than 300. Is that enough? Is that enough to actually
No.
make the case for everybody?
No.
I just have a real problem with this.
No, hold on. Go ahead, John.
The RFPs are going out on Monday, Ross. We have them ready and they're ready to go. We're just figuring out where we're going to send them. Scott is going to review them tomorrow, he says, and they will be ready to go on Monday. That will establish a market. And then we could have a little bit better discussion on things.
Okay, that is helpful. So if we're in a dire situation and we need a doctor for the ER, I'm okay with giving this guy $300 an hour, but only for 3 months. Let's change the term of his contract to 3 months from now. We'll do our RFP. We'll see what the rate is, and then we can make some decisions after we have some definitive data on what the fair market rate is.
I think
With locum that we have, he took himself off of all of his shifts for next week.
I can't hear Heidi. Could you speak up, Heidi?
Sorry, she's on the
We
back.
are in a dire situation. Our physician that's currently a locum now took himself off for all the shifts next week and so forth. So we really need to get this position approved so that we can fill those shifts. You know, it's like I said, worst case scenario, this is a 1-year agreement. You know, we have had other physicians that were at varying rates based upon their experience and their abilities over time. This is, you know, been forever and so forth. So
Then it's not gonna be worst case. If we give this guy 300, Dr. Hall's gonna want 325.
well, we just addressed that last month where we said, and we met, John and I both met with them. And we told them, says that's not going to happen. You know, we recognized that was something that they were doing for taking on extra cases over the 12 that they were required to cover, and so forth. So, you know, we just said the 300 is the 325 that they were asking was not doable, and so forth. So
They currently be.
they're at 280.
So what's the problem with changing Dr. Green's contract to say it's 3 months? We're gonna give you 3 months and then we're gonna reassess the rate after that.
It's a 60-day out contract. You can approve it and you term it 60 days if you need to.
What does that do to all the other positions that are getting 250 and 275?
These are all negotiated independently. Like I said, you know, again, we've had them where some are making 200 above, some are making 175, 180. You know, we've never had that issue for them coming back at that point in time. So, you know, again, it's an individual thing between each position and so forth. So, you know, that is a possibility that it might happen. We just say, no, you have a contract, stick with it. We'll address it at 1-year contract except for renewal. I mean, that's what you do.
Okay, well, I'll probably be voting against this. I leave it to the other board members to decide what they want to do.
Tim, I understand he's a new,
New position to us, yes.
Yeah. he, he's gonna want to be a little bit stable and steady. For him to commit himself to 3 months
Yeah.
is sort of wacko.
Another job somewhere else. He's just coming to help cover. And it's my understanding it would be similar to the last position that we brought on, where like he does a 4-day stretch each month, but he has employment elsewhere. He's just coming like on a
It's picking up
permanent
extra
basis.
shifts.
So he's not making a major commitment like he's
Right.
moved here and everything for
This is
3
just
months.
extra.
So this is basically extra work for a full-time sake.
I'm gonna verify.
I believe that's what it is.
Well, the way it is right now, I still believe I still got my motion in play, right?
Yes.
Okay.
Do you want us to
I
wait?
did second it, but I'll be voting against it.
Okay. Or do you want to take off your second or just keep it and you'll vote against it? So,
I'll just vote against it.
okay. Any other questions?
It sounds like Ross is confused.
John.
John, do you have a question?
Well, so at last month's meeting, there were also additional concerns. So I don't want to, you know, disclose too much. That would be in violation of a closed session thing, but issues with EMTALA, are these other things that were factored into this, Tim? This
That doesn't have
was,
anything to do with this.
Yeah.
There is a color language in
It has in
color language in every ER position contract.
yes.
Did you
okay,
hear that,
well,
John?
yeah, I did, but I understand that every physician contract we have says you'll abide by healthcare laws, but you know, it just seems that since there's been these kinds of issues going on, like I don't mean to say that we're not saying that this physician wouldn't do that, but are we in a situation sometimes where it's almost like we're rewarding bad behavior? Not saying that Dr. Green would, but
It's a new physician agreement. We don't have any history with this particular physician, so I'm not sure that EMTALA is a concern at this point in time.
fair enough. Okay.
we don't have any evidence that it would be an issue.
But would not this be an appropriate time to insert that new provision in the contracts that we use for our physicians to say, if you violate MCOLA, you're going to be penalized X number of dollars for every violation?
I could change my motion to include that, Ross, if we could do that.
Well, we're not, we're not discussing contracts. We're discussing a certain person at this time, right? That we already have a contract in place and we're looking at,
Wouldn't be.
You wanna change it?
There is no contract in place. This is a proposed contract, so it's very appropriate that we talk about the terms.
We don't have.
You have an outlaw.
no, but I mean, we just have a
Really
general
accept
contract.
that?
So let me look at that.
So we're
There's
gonna,
no problem. There may be issues with that, so let me look at that.
Can I remake my motion again? That we accept the contract, and if it's possible to include the Apollo, rate that he wants in that, that he wants in there, then you can do it. Otherwise, the contract stands the way it is.
You can. So, yes, you can make that motion.
Okay, then I make it. Russ, is that okay?
That's good, Gene.
Okay. You still got your second then?
Yes, I re-second.
Cool. You can vote yes now.
so wait, let me get this figured out in my little head. So we're gonna make a motion with the possible changes, even though we don't know that we can make those type of changes yet.
Correct.
Okay, and then we're gonna bring it back next month or,
We're voting on it.
well, and if, I just have a concern.
So I guess the question. So as I understand what Ross has said, if a physician is cited by CDPH or CMS for violating EMTALA, you want to include a penalty in the contract for that violation. Are you talking about if the district is fined, that you cover the fine? Are you talking about a flat penalty? This is new to me, so I'm not sure what discussions have occurred.
Well, it's new to me, but my concern is we have a week or 4 days or however many days uncovered. 4 days uncovered in the ER. How are we gonna meet those at this time?
And Russ,
I give meds at home to my kids. I should be good to do it here, right?
Juggling the schedule, maybe taking some of the positions that are on the end of the month and moving them up just to give us more time to fill it. So, but it is a scramble. And we do have positions that are working 14, 16 shifts a month. And so having another position would help alleviate some of that. But
Well,
we'll
especially
figure out
if there's
something for next week.
concern with things going on in the ER. So,
Has there been any discussion at a committee or otherwise about this issue of
no,
some type of
not that I'm
fine
aware of.
for
This is
EMTALA
the-
violations?
not to my knowledge.
Okay.
And again, a lot of that too, and you gotta be careful with that because like I said, we get hit for EMTALA, other hospitals threaten us with EMTALA stuff all the time, and it's like, because of transfer issues and so forth, but never materialized. So at what point?
I mean, truthfully, Tim, I can see the point that if the hospital was truly fine.
Yeah.
For something that a specific physician did.
Right.
In my opinion, they could be held just as liable as we are. That I don't have. a
Yes,
problem.
I would agree with that statement. Again, like I said, we have not had one of those situations yet.
I'm just saying,
We don't impose that.
Yeah,
No.
so let me explain it. If CMS comes in, says you violated EMTALA. In a hospital, I'm finding you 150,000. This doctor was involved, and doctor, you're being fined 50,000.
he's already being paid.
So CMS would point out all the bad actors. Right now, I've been involved in a couple of these, and I've actually never seen the fine levied. So that's one thing. The other thing is, I don't know that you can go to the doctor and say, hey, we were fined 150,000, you have to pay that.
Correct.
So.
We're gonna find out though.
That is what I would want to look at, because remember, CMS is looking at multiple actors and they're levying fines on those. And first of all, I don't know how CMS is going to feel about that, right? So we need to know that. And second, as a practical matter, are you going to collect this 150,000 from a physician? It might not just be easier to terminate the contract with that physician. So all of these things need to be thought through. And we need to know whether or not it can actually be done in the first place.
That would make it easy to terminate him if he decided not to pay it.
Look, if you got fined $150,000, you should just terminate that physician, right? If a physician caused it, then yeah, you should terminate that contract. So, and your contract covers you in those circumstances. So,
So where's the motion stand right now?
so as I understand it, Gene has made a motion to approve the contract, subject to a review on whether or not you can impose a penalty for EMTALA violations. But the question is, what penalty does the board want to impose? Assuming you can do that, what penalty do you want to impose?
Could it be termination at our, without cause
It's
other
already-
than
It's
that?
already in the
It's already
contract.
in that.
You can terminate it without cause or
For
for,
60 days, 60 days.
but the for cause is not a 60-day notice. It's the for cause.
So why not like a $25,000 penalty that is taken out of whatever they earn going forward?
That's what you need to see, right?
So it would have to be an independent contractor, right? You couldn't do that to an employee. That would violate California law. So they would have to be independent contractors, which is fine. I understand all your doctors are still independent contractors.
Yeah. Oh, yeah.
Yeah, so all the ER positions are independent contractors. So, so you don't have the employment issue. But I mean, the board may want to discuss as a policy matter if you want to do that.
Uh-oh, I've lost the audio. Can you guys still hear me?
Yeah.
Yes.
Who is this? Just kidding, Ross.
Can you hear us?
We're just chatting.
Yes,
Can
you're
you-
back.
All right.
Okay.
In other words, we're at a quandary because we got to make sure it's legal to add in, Ross.
Well, and that you want to do it.
And
Thank
we
you,
didn't
Brad.
want to do it.
Right.
And
I want a disincentive for them to violate EMTALA, because we have one guy who seems to be, doesn't really care about it. And I would like to build that into our standard physician contract, so it doesn't become something that they don't have any, there's no ramifications if they do it.
Well, again, we
And I
have,
want to build that into a contract.
we do have language in here. If, again, if the position, is, does not maintain professional standard of conduct, that's terminable immediately. So you have.
Yeah, I realize we can fire them, but I want their money. If they violated EMTALA, they owe us.
Okay, then can you add the 25,000 rather than the whole penalty? Can you, if it's possible?
So.
Is it about the money or is it how we have treated our patient?
And what if there's an EMTALA violation but no fine?
Right.
Or do you still want to impose a $25,000 penalty? That's why I think it may be worthwhile for the board to have a broader discussion with more information about whether or not you want to go that way. I totally hear what Ross is saying, and maybe the board decides to go that way, but I don't know that we have the information at this point in time to make that decision.
You have to get all the information anyway now. So why can't we do this one contract, if possible, to do it the way Ross wants it? And
Right.
then future ones.
You can't do it.
So what if there's an EMTALA violation but no fine? Are you still going to?
Then Ross still
impose
wants
the penalty?
25
Ross, are
grand.
you hearing this?
Right, those are, I think these
Yes,
are
I'm
things
listening.
that you should all talk.
After you find out what we can do.
Yes,
Okay,
yes.
but for this one, can we do it as possibly doing it? So we would
No.
approve the contract.
it would be an amendment to the contract down the road. Of course, the position would have to agree to that.
And if you were gonna do that, you probably would
Have
want
to
to
do it with
amend
all
the contracts. If that was the case. So it's not one guy.
Or you could, I mean, you could start now and.
It's starting with this one.
But
You can't do it until.
But we don't know what you want to do. So it would be hard.
Because we don't know what we can do.
That's right.
Right.
So I've never seen this type of clause before. I don't know if Tim or John have. I've never seen this type of clause before. It's like a liquidated penalties clause in an independent contractor agreement. And there are rules for how you impose liquidated damages. So, because that is well developed, or it's statutory law in California.
Different than Santa Claus.
Yes, it is. It's not Santa. Well, it might be for you guys, but yeah. So, and then there's the collection issue.
Okay,
Right,
we need to investigate. Can we wait, Russ, until we approve those next contracts, which is coming up, right?
They come up frequently throughout the year.
Well, isn't that raise thing, is it just a raise? It won't be a new contract.
No, any adjustment to their pay comes back as a new contract.
Okay, so we could address that then, I think, which is coming up next month. The whole thing. Okay, do I amend it again?
No.
Okay,
So do you want to approve this contract without that clause
yes.
while you determine whether or not you can
Yes.
do it and if you want to do it?
Russ, is that okay?
Withdraw my second. Somebody else can second if they wanted to.
I don't care. Either way, I don't care. I'll go either way. We need to approve it.
That we approve it. And then modify as information is provided. So that gives us the 60 days at this point. That it could be changed at any time, the contract with him. Right? It's a 60-day, we could let him go, or,
Yes, you have a 60-day termination.
so I mean, if we present it and then he says no, then
Yes.
we're done.
Yeah, Russ, that sounds like a reasonable thing. Because there's so much unknown what we can't.
So you made a first. I'll make a second. Any
It's a straight
further,
contract.
any further discussion? Right. John, you have anything you want to add before we take a vote?
No, those are my concerns about the Impala and the violations and whatnot.
Okay, so let's take a vote. Gene,
I'm confused. Yes. Yes.
let go of his board there, John. Fred,
I don't think he saw it.
John,
Yes.
Russ,
Voting no, based on the rate.
I'm a yes. So the motion passes
Okay.
4-1. We'll review it at a different time, but at this time, I guess the board's recommendation would be, Scott, if you could follow through and look and see if that's something we can, if it's even legal to put in a contract. I mean, I don't know. And
Can I ask a question?
you can.
So Scott, what does that mean now? It's, we can employ this doctor or we have
Yes.
to wait?
Yes, yeah.
Yep,
No,
contract.
we can.
Okay.
It's the agreement, Tim needs to sign it, the doctor needs to sign it, but I think he's got converted privileges, it's on the national system.
Okay. I'm tired now.
Only halfway through, girl.
Yeah, I'm thinking about going to medical school and being an ER doctor.
Yep.
Yeah, how much time do I have?
How much? That's a very broad question.
With health, you got about 3 weeks.
Okay. All right. So we have come, oh my gosh, we have come to director's comments. 8. John, do you have any comments?
Just thank you, acting Madam Chair, for filling in for me since I can't be there in person. I thought you did a really good job, so
Thank you.
you.
Thanks for leaving the gavel for me.
You're, you're welcome. But I also thought it was really good discussion today. These are really legitimate concerns, especially, you know, with the ER and these contracts. But I felt the discussion was really good today. So
Thank you, John. Jean?
John, I love you guy, but I think she did a hell of a good job. I'm not saying you didn't do a good job, but
She
at
did.
any rate, you did a great job. And our CFO, CEO future is, I'm so happy to have him here. And not that I want to see Tim go, but it's a wonderful world today.
It's a wonderful world today. Thank you. Ross?
Thanks, Catherine. Thanks for taking the gavel again. I appreciate you stepping up. So two main concerns I've got are regards to the long-term viability of our revenue streams, the IGTs and our skilled nursing facility. So I appreciate John and Tim continuing to look and giving us a heads up on what they learned as more of this crisis in Washington, D.C. comes to pass. So thank you for that, and appreciate everyone's efforts on getting the pharmacy up and running and the new facility. It sounds like we're not too far off with electricity being run today. So keep up the good work, and I know we're serving our community well by doing that. So thank you all.
Thank you, Ross. Thanks for joining us by telephone. Fred?
I have no comments other than thanking everyone for being here. Appreciate it very much.
I would like to agree with everyone, but I'm not usually that agreeable. But actually today, it was good discussion. I want to say thanks to everybody that will listen to my prayer when they give me the opportunity, because this place in our world is, this place here at the hospital in our community is real important to me. And our world's kind of in a lot of turmoil right now with the floods and everything that's going on and the loss of life. And I'm just glad that we're here as board members and employees, that we represent a facility that is here and capable of taking care of our community. So I just want to say thank you to everybody that is part of that. And at this time, we're going to adjourn the open meeting and go into closed session. Thank you, everybody.
Hey, Bob, are you up and running yet at home?
My generator at home.
Yeah.
Only on my old, I do want, I just gotta land a couple wires and
So
Am I putting us back in? Or you are?
Go ahead back.
We're coming back into full session. After having closed session, we're going to have the closed session report at this time by our attorney, Scott.
So in closed session, Dina Griffith gave the medical quality report, or briefly discussed the Benson matter. There was no update on Volkava, and the board considered a personnel grievance. No action was taken and no other items were discussed.
And so at this time, our meeting is adjourned. Wait.
The power gavel.
You're waiting all day to do that thing.